When I joined the coalition, I was so delighted to see my friend and colleague and a great influence on how I've been thinking about healthcare on the agenda, and that is Mark Fendrick. And we all know Mark as sort of the national thought leader and founder of the concept of value-based insurance design, or VBID. And as Mark will describe, although he's telling me now he wants to have an interactive breakout session with all of you, so be prepared. But as Mark will describe, VBID is the elegant idea that in constructing benefit coverage and attendant co-pay variables, how much individuals have to pay, we need to be very careful and thoughtful and clinically nuanced in terms of making sure that we do not create economic barriers to high-value services, those services that can achieve better outcome, higher quality, and Mark is about to tell us, lower costs over time. And we also need to be thinking about strategies where, for clinically marginal services, we might begin to think about greater cost responsibility for individuals, so we can move away from very inappropriate demand by individuals for services that are really of no benefit or of marginal benefit. And of course, in his classic way, this is a transformative strategy that if you couple the peanut butter of payment reform and you get the incentives right for providers, and you couple that and align the right incentives for consumers, you have the jelly, peanut butter, and jelly sandwich. And this is a transformative strategy that we need to be thinking about. A lot of the discussion in Maine has been about payment reform and getting the incentives right for providers of care, but equally important, and part of the Symp grant, I'm looking at Ellen, is this concentration and focus on VBID strategies moving forward. So with that, I'm delighted to introduce Mark. Mark is a physician. He actually still sees patients. He's a professor at the University of Michigan Medical School. But for the purpose of today, he's the director and founder of the VBID Center. And again, a national thought leader in VBID strategies. In fact, has been working with folks, including Kevin Lewis here in the state of Maine, been working with our staff in the city of Portland on VBID strategies. So he's a friend to Maine, and we're so delighted that he's here. And again, it's like the universe was talking to me when I looked at the symposium agenda and I came to Maine, and there was Mark Fendrick at our first meeting. Because of the last 10 years of working with Mark. So it's a great delight to introduce you today, Mark.
M-A-I-N-E. I hope you can hear me in the back. I'm going to walk around a bit. I just have to tell you all, you know how lucky you are to have Andy. When we launched our center 8 years ago this year, we called, and we actually thought who would be the first person to keynote our inaugural summit who actually exemplified the idea of multidisciplinary and multi-stakeholder work. And Andy saved the day. He came and launched the center, and we've been running ever since. And I thank you for that, and this is not just lip service about this collaboration with the Maine Coalition, with the National Business Coalition, several of its coalitions around the country. So it's been a great pleasure to meet you. Again, I want this to be a dialogue. I do have some slides which I may share now that Dr. Hazeltine basically set up the whole thing that we're spending too much and getting too little. And before I get started, I want to thank the folks who work for supporting this conference and me to come and talk about this. But the first slide I have, which I'm not going to show, is the slide you already know about how much we're spending. And the important part that I wanted to bring, and hopefully hear from you early on to kick this off, is that my goal as academician for 20 plus years, and in the center in 8 years, is to try to shift the conversation in healthcare. Thank you. Are we on already?
Are we on? Yep. from how much we spend, which is going on in every state capital, in every boardroom, and if people are willing to talk in Washington, D.C., to how well we spend it. And the great thing about the group we've been able to assemble today is we have all the stakeholders here in the room, and it's very, very important for us to think about a framework to lead this transformation, this alliterative transformation from volume to value. I'm very pleased, and Andy and I have been talking about this for a decade, but the fact that people are mentioning this term, what does that mean? And I'm looking for anyone to raise their hand and give their opinion. But as a clinician, health services researcher, consumer advocate, and now policy person, the framework that I have set out is this term that Andy used called clinical nuance. And I don't know if any of you have heard it before, know what it means. My students think I should trademark it. But let me tell you what I think clinical nuance means. Clinical nuance means that medical services differ in the benefit they provide. Right? I hope not all doctor visits are equal. Maybe a cardiologist after a heart attack may be more valuable than a dermatologist for mild acne. Diagnostic tests and screenings may not be equal. Colon cancer screening, mammograms have a higher grade of evidence, say, for ovarian cancer screening and prostate cancer screening, so screenings there. And the easiest way to explain this to at least my mother, who's turning 80, not quite 90s, in her 90s, is that prescription drugs are not of equal value. And the reason why this is so important is that in just about every health plan, public or private in the country, who have not been exposed to this dialogue, or some of our foot soldiers in this dialogue, have a current benefit design that I call one size fits all. Every doctor visit within the network costs the same. Every diagnostic test costs the same. And every drug within the tier of the formulary costs the same. And this is what you're trying to set up. You buy these plans. Some of you create them. You buy these plans. So in the generic drug tier, tell me if it's not different in your plan, drugs that cure or prevent complications of terrible chronic diseases, asthma, diabetes, cancer, depression, schizophrenia, cost the same as drugs that treat toenail fungus and make your hair grow back. Right? Who has the plan that is like that? All generic drugs cost the same. Who doesn't? Who has a plan that doesn't do that? Do you mind? You want to tell me a little bit about your plan?
Well, it's not actually mine, but it's
the plan in which you are a beneficiary of. Oh, maybe you're the CEO of the plan. That'd be better. I'd have you come up here.
No, it just separates low-cost generics from higher-cost generics in a way that provides an incentive for people to purchase the lower cost.
Wow, I've never heard of higher cost generics. So you're perfect. You're not a plan. It's differentiated on cost.
Right.
Is your plan different?
I'm not quite sure. By cost, you mean my out-of-pocket?
Your out-of-pocket cost. Excuse me. Yes.
So whenever I purchase, by the way, I do use generics over that, but I also look at the cost that my insurance company is actually paying for the drug, and that's where the variance is.
Where are you from?
I may pay $10 for a generic, but my insurance company is paying a lot more, and so I look at that number also.
Andy, I talk to lots of people in various, no one looks at the total cost of the drug. I mean, you're going to come on, does anyone else look at the cost of the drug? I mean, that's great. Maine is always different. Everyone's above average here. It's Lake Wobegon. But I will tell you that there are the 5 peer-reviewed studies that have looked at this show that consumers do not look at the cost of care beyond their cost share. I mean, there are outliers, but I think that, and I would hope someone would stand up and argue with me on this. Argue with me.
That's, I believe in Maine, I've lived here all my life, and I think that's one of the things we're going to change here. So patients and consumers do understand what the real cost of medication is.
Now, my friends from the co-op, I should know where the exit is because I'm going to start getting into the troublemaker part. I will tell you that will not happen. I will tell you, if you rely on broader transparency discussions about telling people what things cost to the employer, the city of Portland, the government, whatever else, and you don't pay more attention to what the beneficiary actually has to pay out of their own pocket, you will not be as successful as if you focus on what it's going to cost them or you. So Getting the bobblehead thing is good. Please, go ahead.
You're going to find a large majority of the group market has moved to an HSA where consumers already see the direct correlation between generic and non-generic.
Okay, so, gentlemen, so the HSA means HSA qualified high deductible health plan. And in fact, I wanted to get to that issue. That's like, I only have 3 or 4 slides. That where are we going in Maine regarding these HSA qualified HDHPs? But consumers are being brought more in tune to looking what they're buying, not because what they cost the health plan, because they are now become the ultimate decision maker. And we could get into this discussion right now. There are studies that show that physicians and nurses make terrible decisions regarding their health. And all I'm going to tell you is, people who do not have clinical training even make worse decisions than that. And I think that is why, incumbent upon this discussion, is that I would like to set up a situation where you, the collective stakeholders, decide that instead of cost sharing based on price, you set cost sharing based on value. Right? This is hopefully the light bulb moment. Right? Currently, Americans are incented in healthcare to buy cheap stuff when it comes to healthcare. Right? And in all the sectors of the economy where I would like to see people to be incented not to buy cheap stuff, it would be healthcare. I'd rather than buy cheap cars, which they don't, or cheap laptop computers or iPhones, which they don't, or socks and ties, which they don't. But I got into this issue 20 years because I was seeing my patients being incented to always buy the lowest cost option of everything. And then I found that people, even with really good health insurance, were telling me that their cost sharing was getting in the way of the things I begged them to do. Right, right. So if you look at, if I were to ask you, so we're spending too much and not getting enough, right? Who wants to just tell me, you don't need to be clinically sophisticated, what should we be buying more of in Maine, right? What I'm about here is how much to how well. What I'm really about is reallocating the $3 trillion in the US healthcare. I wish I would have looked up how much we're spending in Maine on healthcare. So since all of us would agree there's enough money in the system, right? That's the fun part about not being in education, where people think we need more schools, or transportation, where people think we need more roads. Republicans and Democrats, management and labor, physician groups, and patient advocates all agree there's enough money in the system. So we have this incredible opportunity to start reallocating. And it's really interesting. I was with a Medicaid director of South Carolina yesterday who has a $7 billion budget. And I said, and he's complaining that he's not spending his money wisely. I said, what should you be buying more of? And he didn't have those things at the tip of his tongue, which is really surprising to me. Please.
Prevention, wellness, behavioral health.
Okay. Can you be a little more specific?
Well, I could be a lot more.
No. When you say prevention, you mean
Well,
screenings.
pardon me?
Do you mean healthier foods in the cafeteria?
Yes. I mean, the social determinants of health, from housing to nutrition, exercise, time to have our providers teach or discuss these things. It's hard to answer a little more.
No, that's
specific.
fine. Some people say mammography. Some people say immunization. Some people say other types of things regarding this. Is anyone willing to take, you don't have to ever play the roles that we really do, corporate business leader. When I ask, what is the goal of healthcare transformation? The answer is always, no. Reduce cost, right? So you can leave. You can stay if you want, but you can leave. The answer is always, always, always lower my costs, right? And Andy knows the VBID co-creator, Michael Chernow, brilliant health economist, not a clinician, from Harvard Medical School. We would get calls from corporate leaders. You're not dressed for the part, but you're doing a good job. Say, we hear you guys are the ones who could lower healthcare costs. And Mike would say, if you want to lower healthcare costs, don't provide health insurance. And start hanging up, but wait, he's like, hang up the phone. It's like, no, that's not what we want to tell them. We want to tell them that they can reallocate and spend their money. But I want to be very clear that the first line of slide number 1 is, regardless of what we're all going to talk about, kumbaya and health and prevention and wellness, other types of things, public and private payers, the first thing they ask me is how I'm going to lower healthcare costs, right? And I've tried and tried for years to change the conversation from how much to how well. And I'm going to end this whenever Nancy says I have to say, now I could do both, thanks to the choosing wisely in the stick part. But it has been extraordinarily difficult for me to invest in what our colleague told me regarding wellness and prevention, other types of things, because regardless of what you want to think, they raise healthcare costs. All of the top things that I would list in terms of what I would put on my priority list for a health plan, they all raise healthcare costs. And the CFO is not happy with that. So we're in this quagmire. So what is your general feeling about moving forward, that even if I make people more productive, if I lower disability, if I lower caregiving burden, all these other things that end up somewhere on the ledger sheet, are we willing to move, are we willing to move away from, you'll look at innovations that actually raise your healthcare costs? Is anyone willing to take that on? I mean, most people say they aren't, so I realize that room is...
Is your proposition that the increased healthcare costs is going to get my people back to work faster, make sure they're there, reduce absenteeism?
Right.
Because if you're doing that, you're saving me a ton on there.
Okay.
And I'll spend...
This gentleman is playing the role of the enlightened employee. Andy knows. I want to know, this isn't really helpful, so I'm not sure if this is helpful for any of you, but it's really helpful for me. So how many of you, so Maine is different, so would we say generally, is there someone here from the chamber, are there employers here that are really taking this broader view that I'm willing to invest in a healthier employee and see my healthcare costs, Mr. CEO, go up 5?
Those two gentlemen are.
No, okay, so that's why I'm a friend of it. So this is atypical, right? And what it's very interesting for me, I used to go, I went to med school to visit the Fortune 50 CEOs and make them feel at least uneasy about the way they viewed healthcare costs, because no other aspect of their business were they basically just saying in every circumstance that we should lower costs. They would always talk about return on investment. I need to know where the exit is, because this is a dangerous part of this. And I would like to hear, from a few of you, when we talk about investments in healthcare, does it have to pay off in a one-to-one I failed accounting, which is why I'm a doctor. But when you say, first of all, you don't know how to measure it well, but are you willing to make these investments in these programs only if they give you a one-to-one trade-off on your...
Well, one, we do not. One-to-one's never going to compete with your CFO, which is return on investment for the national improvement. So you got to do better than one-to-one, but it doesn't necessarily have to be within the same year.
Okay.
So if I can...
You have a longer... You have a 5-year window?
If I get a 5-year return, then they can outpace...
Andy might remember you. Andy knew me when I was completely naive in dealing with employers. So I just have to tell you that I had this senior executive say to me that he would be willing to give me a quarter to get a return on the investment. He remembers this. I thought that was 25 years. And he told me, I'm just telling you this is the truth. I'm like, oh, 25 years, I could get it for you. He's like, no, 3 months. I'm like, don't provide health insurance. So, but I think this broader view is very happy. I'll just tell you in general, because of the siloed situation, I realize largely because 20 years of a coalition, people have been thinking more and more about these types of things regarding what I call the non-medical economic benefits of improved health. And there's a lot of things going on there. I'll just tell you, I've tried to do studies. The Integrated Benefits Institute in San Francisco, a partner of ours, we have worked together to try to quantify these things. Again, I would say in most situations with healthcare, we still don't get to one-to-one, right? So I want to ask how many of you actually are investing in wellness programs? Now, keep your hands up for a second. How many are investing in wellness programs because someone told you that actually the wellness programs are going to save money on healthcare costs? Oh, I thought, Maine people, I was told that Maine people always tell the truth. We have studies that show that over 9 out of 10 organizations, while they have other reasons why wellness, the reason why they buy wellness, the reason why they buy health risk assessments, the reason why they bought biometric screening, there's a lot of kumbaya, positive vibey things that come with people eating carrots and not Oreos. But when the door is closed, not in this very tiny intimate room that we're in today, they will tell me that the reason why they bought the wellness program is someone told them they would get a rapid, large, dollar-for-dollar trade-off. And so is someone willing to attest to that? In the way back, attest to that.
Yes, absolutely. That was our primary reason for going. Our healthcare costs were skyrocketing and unsustainable, and we had a vendor come in and tell us we can save you a significant chunk of change over the course of the next 2 years, and it did bear out. With that came other great things, but it's reached a plateau. So
you said, I'll take it.
We said,
Anybody
we'll
else?
take it.
Are we doing okay with it? Can people hear? Can you hear me?
No.
Okay, good. Does anyone else basically, all good things came of it, but the reason why you dove in was this promised healthcare costs. So I'm a nerdy quantitative guy, and I have tried very hard for years to convince employers to invest in chronic disease and pre-chronic disease management because that's where the money is. Report out yesterday, good timing, Andy and the coalition, 1% of Americans generate 21% of healthcare costs. I've been using 5 for 50 for years and years. 1%, 21%. I turn to organizations that are choosing to invest in wellness as opposed to clinically nuanced value-based insurance designs because of that famous bank robber. It wasn't John Dillinger's, go where the money is. Willie Sutton, thank you very much. You could be. So investing in young people and keeping them healthy as a public health professor is a spectacular idea. But to my 2 CFOs and other CFOs, tell me how, with all the brains and training you have, think that investing in people who have no healthcare costs are going to lower your healthcare costs. You have an employee who's been to the emergency room 3 times with asthma, has been to the hospital 4 times with heart failure, has been smoking and has high cholesterol. Those predictive models of people, I'm telling you, you're going to see those claims next year. The 25, 35, 40-year-old folks who are most of the people enrolled in wellness programs in the United States are not going to have health care costs, right? So this is where, I was invited here to make a little bit of trouble. 5% of people have 50% of the spend. Okay? Tell me what you think. The bottom 50, the healthiest 50% of Americans, healthiest 50%, what is their contribution to healthcare costs? Who's the smart actuary? Oh, you again? You said 5? The answer is 3. So I go to CFOs and say, 50% of people, 3% of the cost, if you get rid of it all, you're not saving anything. I need you to think about demography and epidemiology and prevalence of disease when you're paying 27-year-olds like the University of Michigan to fill out health risk assessments and then not doing anything with the information anyway. Right.
But how many of the 1% have a job?
So, how many 1% are covered?
No, 1%
Are actually working?
using 23% of the dollars, and how many of those actually have a job?
Yeah, good question. And why is that?
Why am I asking? Because you said, how do you save dollars for the CFOs? And how many of them have mental illness?
Right.
Who don't
So I'm going to try to tread water on this. You're covering them. So whether they have a job or not is the question I would like to know the answer to. How many of those are covered still by private insurers like you? Right. It's your claims cost regarding their work and not if they're yours. So someone might tell me, so is retiree benefits still a kind of a thing going on in Maine? I thought I learned that last time. So regardless of whether that person is working or not,
Well, no, you should pull back from what you just said, because you're talking to CFOs, and you're saying, go where the money is. How many of them are paying for those people?
right, that's different, right. If he's covering, no, you didn't say have a job. I was reframing your question is, if you're covering them, regardless if they're working, if they're under your plan, you should care about them.
But they're not, who are we talking about, the payers or the employers?
Yes.
Yes?
If he is covering his retiree,
Well, very few are now.
oh, he said we still are covering retirees. You saying they're not. So, of course, if one approach, again, the room's large, is that if you want to shift these costs onto Medicare, then that's fine. You can shift costs on Medicare. But regardless, if you're high cost, regardless of whether they're working or not, the older they are, the easiest predictive model, the more likely are to have claims. And what I'm trying to do in this, one more minute, is to say, as opposed to the one, I see a hand up maybe, one size fits all, your wellness program is equal, your co-pays are equal, whatever else. The more you understand that you can target your interventions, your ROI will skyrocket. So I have told the University of Michigan not to pay $100 a year to employees to fill out a wellness form for people up to the age of 45. Because that's what my actuary friends have told me, that at age 45, that's the time when you start moving from likely to have no cost to some that you might be identify some risk factors that are modifiable to prevent them, please.
So it sounds like the assumption of health, but we can't use the term wellness. It's use that term employees but that these health improvements, the employers haven't figured out over the past decade that the public health primary prevention doesn't work, and that we have to move into secondary prevention in these health improvement programs in order to get returns. So go in and make sure it's worthless. Do it well.
Bunch of points there. First part is, I don't want to say that wellness programs don't work. I want to say that wellness programs will not save you money, and is unlikely to have large impacts on populations and budgets moving forward. And this gentleman used the term primary prevention are these screenings and true interventions when you don't have any conditions at all. Secondary prevention is when you may have a risk factor or a diagnosis of a treatable condition like hypertension to prevent a costly and important complication down the road. And that is exactly what I'm trying to do. And a close colleague of Andy's and mine, David Hom, who is the HR director at Pitney Bowes, which was the first large employer to put a VBID program in place, has coined this term called just-in-time wellness, which I wish is so clever in the fact it ties into the wellness and the billion-dollar industry and all the kumbaya about it. But just-in-time is a clever way to say, I'm not investing in you healthy folks. I'm going to invest in people I think are going to give me an ROI. So I can see you, I'm going to call you in a second. Just want to say a really, known to put my foot in my mouth, they've done it already a few times. I was at the Institute of Medicine with their value panel, leaders from across stakeholders from around the country. And Mark McClellan, who used to run CMS, turned to me and said, well, I think what you're trying to say is we really shouldn't, we should let these young people go. And in fact, we should discriminate regarding what providers young people should go to relative to those people who really need more integrated, coordinated chronic disease care. And I said on the record, which was a really bad move, I said, yeah, young people should go to crappy doctors. Because what I meant to say is, the people who are really sick need to go to the, if you have capacity issues, need to go into the medical homes first. Like Andy uses the line at the airport. He gets to pass everyone else and we get to stand in line. So this whole idea of targeting, please.
Well, you bring up a great point, trying to move people from the high risk down to low risk as the age and where that's where you can see ROI. But sort of going back to what Dee Eddington's been preaching for years is how do you keep people well in the first place so that they don't get to that point as well. When you have people who are young and are growing with an organization, wouldn't you find that investing in them to help create that supportive environment so that when they do turn 45, that they aren't they aren't at high risk, that you've been supporting them all along to stay at a lower risk?
So I'm not a social psychologist, so these are really good points. I just want to say what motivated me was that large, medium, and small employers came to me by the hundreds and said, I need to know where to spend my dollars on healthcare, if at all, right? So Dee Eddington, also from the University of Michigan, we completely agree on where we are. And the bottom line is Mike and I call ourselves the tortoise in this race, and we never say anything unless we're absolutely sure from empirical data that we know this is going to happen. We have challenged good friends, Dee Eddington, Wayne Burton, Sean Sullivan, all the folks who have made this intuitive, obvious claim, and I completely agree with Dee. If you prevent risk factor progression, you will cost less on health care, right? I say start when you may know a risk factor and prevent it from moving forward. He's saying start even further to the left. That's an empirical argument that every actuary, and Andy's heard this many times. When I got into this, I thought actuaries were people who studied birds. Honestly. Honestly, it shows you, like, I did not prepare for this career. The actuaries look at me and say, people are arguing about this? We know that the one thing that predicts more healthcare expenditure is your age. And if you allow me to collect some information, which I don't argue against, that is fine, but you must be targeted in who you get it from, and most importantly, to lead this.
You're underlying and missing mental illness. 1 in 5 people have mental illness. How many don't show up to work? How many abuse drugs? And you're saying you don't do wellness?
First of all, I'm not missing anything. I'm worried that what I'm saying is not making it all the way to the back row.
You're being flippant.
I'm not saying what I'm including and not including at all. I have to tell you that a prominent component of what we're doing nationally in VBID and in the main co-op is a very strong, highly incented mental health program. So I don't know what you're hearing, what I'm saying. I'm saying that for the services for which there is strong evidence of benefit in health, which motivates me as a clinician, and also value in terms of relative health for the dollar spent, which matters to the CFO. By the way, sir, mental health is at the top of my list, and you could read any of the stuff we've been doing for 10 years, it always is. So it's not like we're missing or not missing. We like to think that we look at populations, we look at interventions, and we want you, as either health plan designers or purchasers of healthcare, to look for a situation where the health plan and the benefit design is not everything for everybody, right? But instead nuanced. I'm going to give you the example that I used to my mother about nuance, just very specific. And Andy Weber was absolutely instrumental in the definition of clinical nuance, in the fact it's services and providers different. Right. Colonoscopy is something I've cared about my entire career. Colon cancer screening, a proven A-rated U.S. Preventive Services Task Force intervention, saved lives, good value. Right. I coined the term the Katie Couric effect. I worked with Ms. Couric on after her Today Show colonoscopy to make sure that she did not say things that were not evidence-based. And it was a fascinating thing for me, and my kids actually thought that was cool relative to this usual stuff that I do. The only thing that Ms. Couric and I ever disagreed on was that the colon cancer research specialists, which I am not, say that because of the human condition, you don't develop the polyps that lead into colon cancer until you turn 50-ish. And that the recommendations from all the societies, you get your colonoscopy at age 50. And she said to me, my husband Jay, who had no family history, died of colon cancer at 41. And you need to change your message to make it starting at 40. And I said, that's not for me to do. The evidence says 50, and that's the way it's going to go. So I have said for many years that people at the age of 50 should have an offer of colorectal cancer screening, average risk on family history, for free. And I say that my most humble accomplishment is that it is now the law of the land that not only will every American have access to colorectal cancer screening for free, they will have access to 57 other primary prevention interventions for free, Section 2713 of the Affordable Care Act. 105 million Americans have already been affected by the idea of value-based insurance design that certain high-value preventive services must be delivered. We went to Congress and said, at lower cost than others. The wisdom of Congress, in quotes, they made them free to patients, not to the payers. They made them free. Unbelievably exciting stuff. However, the nuance part. One, if you're 35 and motivated by Katie Couric's story or whatever else, you should not only pay 100% of the cost of that test, you should be fined for taking your mother's appointment, right? Because there's no evidence to say 35. If you're over 85, it's also dangerous. There's not a Medicare plan in the country that does not cover a plan, an intervention that is determined to be dangerous. So we should be nuanced, free between 50 and 75. Very poor coverage under, very poor coverage over. That's the type of thing I encourage Kevin and his team and others to think about. That's the type of nuance that many plans do. In addition to that, in the ACA it says, you may limit the zero-cost sharing colonoscopy to certain high-performing providers, which was not our motivation. This came from the employer community. That Andy and his colleagues out on the West Coast saw that an employer, CalPERS, was paying between $600 and $6,000 for the same test, and said, we are going to restrict the zero-cost sharing mandate to in-network providers, which added not only the services to the clinical nuance, but the where they got it and by whom, which has really elevated the game even since we last spoke, that it's not just these things are low cost, but these things are low cost only if you go to certain places, right? Which is why we try in our benefit designs, if you go to a medical home, your cost share should be lower than if you don't. If you go to the designated center of excellence for a rare cancer, your cost share should be lower for both. And when Andy and I got started, these were concepts. And now we see that Lowe's sends every one of their employees anywhere in the country to the Cleveland Clinic for their heart surgery. Not the cheapest place, but they viewed it to be the best place to use their resources. So it's not just the services, it's now also where they get it done. So you're waiting.
Can I just ask a quick question out of curiosity? I'm not an employer, but where I work, there's one of those cost of living and
Of course.
with an incentive to participate in a low premium. Can you target that legally to people over a certain age, like we're talking about? I mean, what are the legal limitations?
So what are the legal limitations? So first off, my mother thinks I work for the CIA because I travel around and do this stuff and not see patients all the time. And you asked me a legal question, right? So I'm not a lawyer, although my wife is. We're doing this, so everyone, most of the employers, large employers, whether you are running one or in one, disease management programs have been around for 25 years. So in other words, if you have heart failure, you get a better benefit. If you have AIDS, you get a better benefit. So just moving cost sharing for services based on a particular condition, outside of discrimination laws, whatever, I don't know. Well, they've been around forever. And there are programs that do these interventions just for certain patient populations, which is the ultimate motivation for me to tell you in thinking about your benefit design, right?
But I'm thinking of age.
But you can discriminate by age, you can discriminate by gender. I tell this story. Ann Arbor patients on general come in with about it used to be 90 pages, now it's on their iPads, of stuff about their own conditions that they know more about than I do. There was a new drug for prostate health that was introduced on TV. A woman came into my office, and I'm a complete pushover. He asked me for drugs again. She said, I need this new drug for prostate health. And I said, finally I've got an instance where I'm going to be tough, because women don't have prostates. I figured, I'm going to win. This one I'm going to win. So I tell her, I said, you don't have a prostate. I'm not prescribing it. She said, if it's good enough for men, it's good enough for me. So these things are hard. So I wish I could make this stuff up. I mean, this stuff is hard. So I don't know the real answer. The point of the matter is, Aetna has this excellent program where, because CFOs wanted a VBID intervention that actually at least was cost neutral early on, just carrots only, we had to target. And as Andy knows, I take a statin. Thankfully, I've not had a cardiac event. If you've had a cardiac event, your likelihood of having another one is 20 times higher if you have had the first one. So we said, we've always wanted to make heart drugs less expensive, but if you make it in the people who are likely to have a spend going to this, not the healthy guy with high cholesterol, the person who's had a heart attack already, very high risk. We modeled this for years. We know the costs are going to be high, and these people are typically working. And so we made, for people with heart attacks, in the Aetna commercial database, 4 drugs that have been shown to reduce your second heart attack by 50% and made them all free. All brands, generics, we didn't put any, all free, not lower like we do in most VBID programs, free. They've had a heart attack, they've been in an American hospital, they've had their groin invaded by some young doctor didn't know what they were doing, to look at their coronaries and put in unnecessary stents that you're paying for, but let's leave it aside. They all go out on the same medications. They got them for free. How many of them took them?
Almost none.
The study showed the rate of adherence went from 42 to 49%. So that's why when we look at designing plans like the co-op here, it's benefit design, it's nurse support, it's literacy programs, it's all the things that go far, far, far beyond what we do.
So how do you address this issue in populations with legally restricted setting? Of steering?
You're not a plant. Ellen, you're not a plant, right?
I'm not.
I haven't seen Andy for 7 months. I said, we've had some major...
Ellen works for the coalition.
No, but we've had some major... So the question is, what about Medicaid? So one step back. Excellent question. So I think people are getting the gist of what VBID is that instead of this benefit design that encourages good stuff and bad stuff equally, we want to put a program in place and start having people in the room start doing this or doing this. I want to start reallocating how we spend our money. I want to incent physicians and health systems on the peanut butter stuff, really sophisticated, way above my pay grade, pay for performance, ACOs, medical homes. I want to align what we're doing with patients to basically have my patients say, Dr. Fendrick, you said this is important. Isn't it great that you're going to make my appointment? It's not going to cost me anything. The clinic's going to be open at the time I need it, right? And they're going to treat me nicely, and they're going to, I'm going to be all the satisfied things. This is what we're working on, and this is what we're trying to get. So I didn't even get to her question. So my brain, I can't store. I have no extra capacity here. So I see you though, and okay. So our mission of our center was to make every American have an access to a plan with VBID principles, right? So I stand here in Maine knowing when the exchange opened, October 1st, I could say that's on my list. If you go on the exchange and you want a VBID plan, you could find a VBID plan. I only know of 5 states that I could actually say that now, in addition to Maine, who have that, right? So commercial, we've been great and self-insured. Big firms have done this. Fully insured, getting there. Individual markets, getting there. Medicaid. 2 years ago, we thought we had no shot. One is because under the 100% federal poverty level, our own work has shown $1 cost share really deters adherence. And by the way, most of my colleagues, like myself, who see predominantly Medicaid and uninsured patients, it's not worth it for us to collect the copays because they're so low, and it's just administratively, things that I don't understand well, not very much. This year in February, CMS passed a final rule that allows us to do VBID in Medicaid. It is, it's, $0 to $8 range, which may not be a big deal for you, but in Medicaid, in terms of getting to steer people to go into a medical home at 0 cost share and go to see an emergency room or a provider who you don't have continuity with at $8, we are hopeful that people will respond to these types of things. Most Medicaid formularies, generic drugs, free or close to free, all branded drugs, not. I like branded diabetes drugs to be low cost. I like branded asthma drugs and schizophrenic drugs and other drugs that when people can't take generics to be low cost. And we're seeing now movement in now 6 states putting VBID into Medicaid programs since this rule is out. And when Michigan passed their Medicaid expansion, the bill was signed 3 weeks ago, Monday, there is an explicit line in the law that says they must put a VBID cost-sharing program in place in their plans. Right? I went to med school. I wrote that legislation. Now I went to medical school to write legislation, and we are scared to death now. That is Kevin and Maggie and the team from Co-op. I used to say, if we build VBID plans, right, if people know that compared to this one-size-fits-all non-nuanced plan, and they have a choice to buy a plan that actually has co-pays to encourage more of the good stuff and co-pays to discourage less of the bad stuff, I used to say, if you build it, they will come. 2013, 14 is coming around. I'm scared to death because there are plans that actually have these elements in place. And I just keep thinking that most Americans, if given a choice, and if they take the time, right, they will choose these things. And that's what I want. I'm not sure if they will or not, but that's what I'd like to hear from you. If you had them offered to you, do you think you would buy them? Please. Yeah, your turn.
So I wanted to compliment you on the idea of leading the co-pays or force of the drug with people who are post-heart attack. I believe that this weekend is when we have sort of primary or basic elements of value-based purchasing and then design already being attempts to pay money to the right things and increase co-pays for items that have low value or things we want to disincentive. Very much interested in more advanced concepts like that because we're struggling now to research and read all these people are published with very innovative value-based benefit design. And we're like, yeah, we've done all that already. So I need like the next generation of what you're talking about.
Okay.
Could you?
We can talk offline. Yeah, so where do we go for the next generation? And I'll just say, because the university is not interested in these specific consulting things, and I did not plan to say this, our advisory board of our center, of which Andy is a member, insisted that Mike and I create a very small boutique consulting practice to answer these types of things. So it makes me a little uncomfortable, but we could do this, and we've worked with organizations in Maine on this. But I think the larger thing, I don't believe you that most people in Maine actually have VBID principles in place. And here's my litmus test. So most of you raised one since it's all. The great thing about here's the litmus test. This is when I went in front of Congress. So these people are nowhere near as smart as you, right? So this is the example. So why the nuances depends on not just the service, but also the population provided. Everyone in the room probably knows that an eye exam for a diabetic every year is a quality metric. It's in every HEDIS, every National Quality Forum, whatever else. People without diabetes, as you know, do not need to see an eye doctor every year. The evidence says, maybe you have to go every 5. How many of you have a health plan, either design it or are in it, that have a lower cost share for a diabetic eye exam than a non-diabetic eye exam? So do you have that? No, but I don't view that as detail. I would say that all of you, either buy or involved in health plans, have quality metrics. Right? That's the peanut butter side. And I went to Congress, so I'm going to get back to the high deductible health plan point made in the back. I am in a medical home with a very robust pay-for-performance program. I am paid lots and lots of extra dollars to get my diabetics to get eye exams. Not the 94% of my patients who don't have diabetes. Right? In Michigan, the fastest growing type of plan is an HSA qualified HDHP, high deductible health plan. And for those of you who don't know these plans, is that until you meet your deductible, you pay 100% of the cost of these things. So I'm going to turn to my CFO. You are paying me an incredible amount of incentive dollars to get my diabetics to get their eyes examined. The cost of my patients to get their eyes examined have gone up 6 times. At the same time, they're paying me, so I'm begging, I'm in my office, I need to send my kid to college, please get your eye exam. And they're like, I want to get my eye exam, but I have to pay 100% of the cost of the thing. So you guys are smart. Right? What is the thinking that you will encourage one side of the equation to do certain things, and at the same time you're discouraging the end user to do these things? And this is when I go into CFOs 101. They say, Mark, diabetic eye exams are going to be free. And we have been successful in 300 self-insured companies because they've been silly enough to invite me in, and I give the diabetic eye exam story, they feel stupid, and they make them free. Right? Because it doesn't make sense. And so I'm just trying to hear from someone like, who's thinking about the peanut butter and jelly at the same time? And I get to a second. I had another hand, I thought. Okay, who's thinking about that? And hopefully it's you, Skippy and Smuckers.
Yeah, so in the account-based plans, we like to call them account-based plans because marketing purposes, going behind deductible plans doesn't sell as well. But in these account-based plans, we run into the problem of the requirement by the feds, in their brilliance on this, to have people exposed to actual market price unless the service is on the IRS's list for covered preventive services. So I'm really curious about how you've worked with folks who have these plans, because we do. They do expose people to the cost. They do get very serious about what they're paying for. How do we bring these concepts in when we run afoul of the feds and pass that liability back to the employee who uses the HSA to cover services incorrectly and then ends up getting hit with excise taxes?
Okay. I'm glad you had the mic. So this is my, the Washington Post yesterday, and good time, and Hewitt published a survey of their large employer clients about their movement to high deductible plans. So can I ask, is it multi-stakeholder issue? High deductible health plan is a major issue on your table regarding benefit design moving forward in the next 3 to 5 years. I want someone to say, like, we're never going to go to HHPs, or someone who represents, like, the SCAN, maybe some from the coalition. HHPs are, like everywhere else in the country, becoming more and more of an issue because you can't afford to pay it all and you got to put more skin in the game and other types of things. This is an unbelievable, folks in the front are just great plans for me. There are two, when I explain the VBID concept to any stakeholder, and this includes now over 50,000 AARP members, just see, because I was asked to testify, as I mentioned, about VBID in Medicare, let alone Medicaid, which is the next big step for us. And we need to make sure that we had all the coalition, small c, coalitions of stakeholder groups on board to say, you know, we should have variation in cost sharing, that diabetics should have better access to eye exams, and people on Coumadin should have better access to blood tests to see how thin their blood was, and all these kind of obvious things, which I'm happy to give you a list later. And so people get it. And this is kind of captured by a moment when I was asked to testify in front of the Medicare Payment Advisory Commission, when Rob Reichauer, Randy knows, asked me, he said, I get this idea, more of the good stuff, less of the bad stuff, sounds great. But this is Washington, where every issue has winners and losers. Who are the losers in value-based insurance? And I said, off the top of the bald head, I said, the losers in value-based insurance design are the people who are making money, not making Americans any healthier. And you can imagine, in a room during healthcare reform, where people spent $1,000 to have some undergrad sit in a seat, no one was willing to admit that's them. Right. My first foray into policy, no one is willing to say that the wonderful status quo that we have is better than what I'm suggesting. It may be hard to do, there may be issues of discrimination, selection bias, cost, and actuarial things, whatever else, but no one is pushed off on the idea. So why is high deductible health plans 30 times more prevalent than VBID plans? The answer goes back to the history between Andy and myself and my first question. 1, VBID carrot programs do not save money. And our backers, our sponsors, hated when I say that, but Chernow and I would never go on record to say, at least in the windows that most CFOs wanted, that as more people took their drugs for diabetes, and more people took their drugs to quit smoking, and more people went to physical therapy after hip replacements, and more diabetics got their eye exams, and more women followed up on their mammograms, their costs went up. And that is why I believe that VBID programs have to move forward. Thank goodness, although in 2005, Andy said, Mark, enough of the carrots. Tell me the sticks that we shouldn't pay for. And I take very, very tiny credit for motivating the Choosing Wisely movement, because I needed VBID plans to be cost neutral, to your point. I needed them to be neutral. I couldn't make them neutral unless one of two things. I showed productivity and disability, which I haven't been able to do in 10 years, or I convinced payers and patients that there are things that you're buying and covering now that harm you. This is not 2% of spend. People say this is 30% of spend. And thank goodness I'm teeing up Choosing Wisely. Much better term than value-based insurance. Choosing Wisely. I wish I had some marketing background. Choosing Wisely is this, Andy mentioned, motivated by the clinician community telling you that there are billions of dollars of things you're buying that you never should have been bought. And now I say to you, Andy, I can make a VBID plan now if you allow me. carrots, which motivate you, and sticks that I use to keep you happy, CFO, we could do it. Any price, any level, whatever you want. And it's taken me 10 years to be able to say that to you publicly. So that's one. We're ready. The problem is, these incredibly astute folks in the front row, I am confronted now with this movement around skin in the game and high deductible health plans. I would like a high deductible health plan that made bad stuff high deductibles. I want good stuff to be low deductibles. And it turns out that, again, the wisdom of the Internal Revenue Service has tied the hands of large and small employers and insurance companies to make secondary preventive services, i.e. the diabetic eye exam, before the deductible. So this is a wonderful subject. The top priority for the Center for Value-Based Insurance Design to allow VBID to move forward is to march on the IRS to change this rate. So, now, I see a hand up. Is that a checkbook? Is that? No, oh, I thought, no, Andy, I got you. But, so, we are, I live this charmed life. Senator Tom Daschle has volunteered to start a nonpartisan, multi-stakeholder coalition to help us make this change. So I still think it's the sticks that are better, but for those of you who want the VBID, HSA, HDHP hybrid, you can't do it. That is the best excuse. You can't do it even if you want to, but hopefully a year from now or 2 years from now we'll be able to do it. Please.
So when you march, the new regulation around a cap on out-of-pocket at $6,350
For individuals.
should also be removed. Because if you are going to penalize people for making the wrong decision, there needs to be a financial consequence with doing that.
So I have this really cool 3D figure that basically says, for the things that Andy and others, the quality people come up with, they should always be free or low cost, and physicians and clinicians should be paid lots of money to do them, right? And then you should always have certain things that never count to your deductible. And the sticks, so you can imagine in my brain this newfangled design that the co-op's got to roll out here in 3 years when we fix all this bad stuff in Washington, is going to have a lot of these elements that basically say, if the evidence suggests you should get it, it's going to be low cost to you, it's not going to count for your deductible, and physicians and clinicians should be paid a lot of money to do that. Even I go and say it should be paid fee for service. There should be no, it should be outside the cap on the peanut butter side, which the doctors love, because they're going to get paid a lot for doing great things. And at the same time, some things should always cost you a lot. And I believe that even in that out-of-pocket max, there are some things like cosmetic surgery now that don't count to that. Imagine that we just put unnecessary MRIs for back pain in that category, which the choosing wisely people are starting to think about those things as well. So we're all on board? That's it? What about implementation? What about other problems? What about discrimination? What about that you need help choosing good and bad stuff? What are the issues here?
So Mark, tell us about how health plans are responding to the administration of value-based benefits, because clinically nuanced coverage also is a challenge in terms of just basic administration of the benefits.
Would it be appropriate to have one of our colleagues from the coalition say a little bit about what they're doing? It's live, it's public, it's complete information. Is that? I mean, I get to come in and say, this is what you should do. You should make diabetic eye exams free. It's hard to do that. I think it shouldn't be hard. As Jill Berger was with us over the past 2 days, head of human resources at Marriott International. Interesting that Marriott International was the first large company to go with value-based insurance design besides Pitney Bowes just picking 1 or 2 drugs. Interesting thing about the hotel industry, this is not like manufacturing or utilities. There's tons of churn, which is something that you guys, I thought, would bring up. Why should I invest in this if they're going to go work for Hilton or Starwood? They picked that. Also, Jill had to launch her VBID program in 43 languages because associates that work for Marriott are in 48 states from all over the world. And Mr. Merritt himself, I had the privilege to meet, just said, this is the right thing to do. That drugs to treat depression and schizophrenia and smoking cessation and high blood pressure and cholesterol should not be a burden on my associates. Generic or brand. right? Not just cheap stuff because they're cheap. Make them inexpensive because they're high value. And this has really been a paramount thing for us. Jill has now expanded this to prenatal care carrots. She's also put a stick in place for elective induction and C-sections for people who want to have their kids born on 12-12-12 or things like that. So she's starting to manage not only the carrots across the continuum of care, but also think about fairly easy entrees into the low-value services realm, so she understands that she has to expand the stick side as well. But I didn't know, can we hear from anyone in the audience, including Nicole?
It's interesting you talk about a heart patient.
You're standing up now, so I'm going to sit down.
Who had issues and had a heart attack, an incident, and 51% still weren't taking the medication they should have. And then you have individuals with high blood pressure and also people who have high cholesterol who are taking medication, not taking care of themselves. It's part of the root issue that people rely upon technology to make the fix instead of a personal responsibility of taking care of themselves.
Right, so this is the hardest part about our earliest conversation, a little bit tension in the room about why should I invest in people who may have not lived the stealth lifestyle of our CEO here and done all the right things and subsidize the people who smoke and drink and whatever else. This goes back to our relationship where the CFO said to me, tell me in healthcare where I get the biggest bang for the buck. So I was forced to be a public health guy pushing all these, what I thought, high health gains because I thought that's what businesses wanted. No, and they told me, door closed, that's not what I want. Tell me the investments I should make that are going to improve my stock price. And that was, very transformative for me, but why I've worked so closely with the Business Coalition, saying, tell me what you want. While they would like people to eat more salads, they would strongly prefer to have the person out of the hospital with the asthma attack that's costing them $32,000 every time around. So the personal responsibility stuff is difficult. I am a huge supporter of very aggressive coverage for smoking cessation programs. Even I have argued to go beyond free, that people should be sent beyond free. Some from the co-op, I think we have a very strong smoking cessation program. People say, what about weight management? Because we don't have an effective intervention, right? We don't have nicotine replacement, Wellbutrin Chantix, right? I don't have a VBID program for weight management because the evidence shows that A, it's hard to get people to lose weight. There's no evidence that if you lose weight that you lower healthcare costs, and that's what you want from me, right? But 9 times out of 10, large corporations have weight loss programs, and programs get people to lose weight, and they still make their diabetics pay for eye exams, right? And when I leave, they still have their weight loss programs, but at least the diabetics get free eye exams. And that's all I'm trying to do. I love wellness. Please.
Steve? Oh.
No, go ahead. Oh, someone at the microphone already? Oh, sorry. Didn't see you, please.
I wanted to bring up a point that you mentioned in passing earlier, which is the identification of value providers. Because I see this as a thorny topic in this transitional time. Maine's a rural state. I'm sure it's true elsewhere that you're having small organizations who are trying to flip from what they used to be doing to this new model. A small hospital that's dependent on their lab costs, their orthopedic surgeon and such, they're not going to get paid that much money for physical therapists instead of the orthopedic surgeon, or for primary care instead of some of the higher end things. So you will have a transitional time, and they're going to get hammered during this transition, and I don't know that there's a good answer for that.
Well, so that is a terrific insight, which is why I am strictly a Welch's jelly guy and leave the smart peanut butter payment reform stuff to other folks. But here's what I will say to you about why I've gotten involved in this, is that medical directors and executives in insurance companies, in the first 5 years that Chernu and I were doing this, kind of thought, this is kind of cute, what Mark's doing, making insulin less expensive. Right? It makes a lot of sense, and the drug thing and a few of the high value things, low-lying fruit. And then I got to go to DC for a meeting at AHIP, and I said, Andy Weber and the employer community want to bring in the provider side to this. And when the insurance companies realized that they could use VBID to steer patients to the doctors they want people to go to, that's when we got like our second, we have no venture capital, but we got this second influx of real interest, and we had this logarithmic term because all of you know, although there may be some plans with no networks in Maine and some with networks, the idea of who you go to has been a very important aspect of insurance plans for as long as I've been studying insurance for 25 years. The solace for me is that the early narrow networks were based on cheap doctors and cheap hospitals. And because employers have gotten a little bit more astute with the value proposition on the provider as opposed to the service, I really do believe that high-performing networks, as they're called, have to, at least on FOSS, have something regarding not just cost. And that whether it's my example of the Cleveland Clinic in heart surgery or University of Pittsburgh in transplants, there always had kind of been on the orphan clinical condition situation, people know it's always better to go to certain places. Now, on the macro level for us, the implementation of VBID around steerage is this medical home, no medical home thing. It's happening in private plans, it's happening in Medicaid plans, and we hope soon to have it allowed in Medicare Advantage plans. And I am not the judge to say a medical home is better than a non-medical home, but there are a lot of people, some of which here today from NBCH and maybe NCQA to tell you that's probably the right way to go. But yeah, it's probably, the peanut butter side is much more problematic, I think, than what we're trying to do to steer people. Please. Excellent. So, how many states down is it? So Connecticut is, so I'm going to forget to say this because we have a center of 2 FTEs and I've got 12 unbelievable students who work with me for free because this is experiential learning and it's fine. So you can find a lot of the things I've talked about all available for free on the center website. Google VBID or Firefox, or I don't want to give any credit to Google. We passed vehicular borne incendiary device about 7 years ago, so we're the top VBID. All this stuff is free. And even better, you'll make me happier if you follow me on Twitter. I can't believe I'm saying this because I was forced. UM_VBID. All the things that I think most of you are taking time out of your busy schedules to hear this, I use the VBID account as a place to put the stuff that I want to read on the weekends when I'm too busy. So it's almost all about cost and quality and transformation and other types of things. And some things are a little more clinical because I am a shallow guy. Some things are more business, but I'm trying to get there. We passed 1,000 followers and going for 1,100. So maybe. So on the website, because Andy was so instrumental in this, I wrote like 100 academic, now it's like 250, 100 academic papers at the time. And I realized that the people I need to reach were people like you, the ultimate decision makers in healthcare transformation, not my academic colleagues. So I say, I published and I still perished. And what we do is create 2-page briefs on subjects that might be interesting. We wrote a brief on VBID and SIMS. And Karen Murphy, who runs the SIM program, said, this is unbelievable. Maybe I hope you guys in the SIM were on that webinar. I gave a webinar on VBID and SIMS to every SIM participant in the entire country, which is, we have a lot of, so our shining example of VBID implementation, you say, what about labor unions? When Governor Malloy was elected, Governor of Connecticut, he inherited a $3.5 billion deficit, and the first thing he asked the labor unions who supported him almost unanimously when they voted for him to give them $3 billion in cuts so he could balance the budget. And of course, all of you know that we get cuts in labor, it's healthcare all the time. I was very fortunate that the consultant to the labor unions in Connecticut misheard me, and he heard, oh, we got this VBID idea that helps people and saves money, which I've never said, but you want to believe, oh yeah, VBID's. So this is before Andy convinced me, but kept sticks in place. So they called us, we created a VBID plan. These labor state employees were in a very, very rich PPO that they were very happy with, okay? So I wish I could take credit. Very, very smart, all the consultants. We created the VBID plan with all this personal accountability and all these things that, at least because I don't know labor well, labor union doesn't want to be accountable for anything, blah, blah, blah. We created this plan. You had to go to your doctor every year, you had to get age-appropriate screening, and we had VBID programs for 5 common chronic diseases that we all, asthma, diabetes, hypertension, depression, etc. The smart thing they did was, you had to opt into the VBID plan, but if you didn't opt in, you could stay in the PPO. It was $100 more a month, and a new $3,500 deductible. And the interesting about this, because politics and policy do not often align, Andy, was everyone in Hartford wanted everyone to stay in the PPO, because that meant $1,200 cash into the treasury for everyone who stayed. And I'm like, right? So I'm weeping. Like, but no one's really helping me. I'm like, this is my incredible opportunity to get populations into a VBID plan that I helped design. So I'm sitting there in Ann Arbor saying, I've got a lot of patients who are in labor unions, and $100 a month is a lot of money. And the biggest actuary in New England, so he's like 480 pounds, biggest guy, says 30% of people will move into the VBID plan, but I'm going to budget it at 50 in case not enough people move and the governor's not angry. So how many people moved? Yell out some numbers.
90%.
So the more you think you know, this is doing this now for 2 years, the smarter you are in this field, the lower your number is. The more you know, oh yeah, Mark's going to trick you, you're going to say a high number. So 3 days in, 68% moved. I'm like doing the Macarena and everyone else is crying. End of the week, 98% in 1 week moved from a PPO with doctors they knew with low cost sharing and no accountability into a VBID plan, which said if you don't go to your doctor and you don't get your colonoscopy at 50, you don't get your mammogram at 40, get your A1C checked if you're diabetic, you're out. Right. Kevin Lembo was our meeting yesterday, comptroller of Connecticut. 2 years in, 98% of the employees are doing what they're supposed to be doing. Costs are below trend, ER visits are down, medication adherence up, ambulatory care visits up, specialty visits down. Right. And he said, you can't say that he's saving money, but he's about neutral with no sticks. So we have examples, and I could give you the name of the guy who runs the Coalition of Labor in Connecticut, who has now trained AFSCME, SEIU, 1199 folks to say, you know what, as opposed to taking across-the-board copay increases in your negotiation, why not argue to keep the good stuff low and the bad stuff high? Please.
When compliant with the guidelines, they that should know.
Yeah. And so that's, I call that the frozen carrot. Right? They're brilliant with this frozen carrot. So
Mark, repeat the question. You couldn't hear it.
Yeah. Right. Here we go. No, Nancy's here. Nancy's scaring me. I didn't forget it. You thought I forgot it, didn't you? Yes, I did. Oh, you forgot my question.
The question was, the employees who are non-compliant with the VBID guidelines, do they get bumped back into the PPO? And is it 1 offense, 2 offenses, 3 offenses?
You can imagine, so we were talking about this earlier this morning, how they're going to police the bounce back is something that's still being negotiated. Because of, interestingly, which may be a main issue to the comment about the rurality, if that's a word, ruralness, what's the word, rural aspect. We had problems, people were so excited they didn't want to get kicked out, they started trying to make appointments with their PCPs. And since everyone was in, as opposed to the Fender rule of only the sick people get to see the good doctors and healthy people see crappy doctors, everyone wanted to see their PCPs and they couldn't. So they had some problem with the overwhelming response that people wanted to get colonoscopies. Imagine that. I mean, it was just amazing how. No, and I want people to really want colonoscopies, right? But I don't want people to get prostate cancer screening. And so that's what we're seeing, is that we're seeing this reallocation, which is, as we're starting to wind down, the reallocation is what you should leave this session with. And whether it's just your organization saying, I want diabetic eye exams to be lower cost, or the full-blown co-op, let's think about VBID not just in drugs and in devices and procedures, but in behavioral health and choice of centers of excellence and other types of things. I love it. Are you fee for service?
I can.
It's on.
Speaking on the unions or the collective bargaining agreements, so that's a service union. Can you me give a specific example with a manufacturing labor union.
So is that, would UAW be on that list?
UAW
So
would
you-
be on that list. yeah.
UAW, so some of you might know, the largest transfer of capital in the United States history occurred 5 years ago in Detroit, where the liability for the retirees of UAW was moved from some virtual bank to another virtual bank called the Volunteer Employee Benefit Association. So the fact that we have the VBA supporting VBID principles is nice things for me to say. So it's not the full-blown type of thing. I think the VBID is that certain generic drugs, we have a high value classes of drugs that regardless of the tier they're in, the drugs cost less. So imagine drugs for diabetes, the generic drugs with maybe $4 go to $0. The branded drugs like Januvia, which now are ridiculously out of price, will get cut in half. And the non-preferred drugs that you don't like are also cut less than half. So the point is you guys want to operationalize this. I strongly believe, as you said earlier, I believe in tiered formularies. But I believe that within the tier of the formulary, there should be high-value generics and low-value generics, not based on price, right? High-value brands and low-value brands, and high-value not-preferred brands and low-value brands. The thing I want to bring up as we're taking down here, specialty pharma is, for those of you who are like thinking about, specialty pharma is the thing that most people who actually work for large firms, we've kind of leveled off, although the rate of growth is 2 times or 3 times inflation for visits, hospitals, and small molecules, typical drugs. The high cost, specialty pharmaceuticals are the ones that most employers are having to be worried about. And I got to tell you, this is where to end go. So I give lots of talks, and I hope you don't mind this not presenting slides. You'll evaluate me, invite me back or not, whatever. But I've only been interrupted one time in my entire career with a standing ovation in the middle of an academic presentation. No, I'm not expecting one. Please don't. Because you're going to feel guilty. You're from Maine. All right, I'm getting the second one. Now, I wanted to stay at 1. I needed to stay at 1. I was talking in front of 2,000 people who worked in the field of oncology. And everyone who's known, maybe you have some, unfortunately, known some with cancer, whatever else, but there's a number of specialty pharmaceutical drugs, and these drugs are the leading cause of foreclosure and bankruptcy in people who apply for medical bankruptcy. And it turns out that I believe in every plan in the country still that has a specialty pharma tier, it's all cost sharing, not co-payment, so it's a percentage of the cost, and it's across the board. So there are some specialty drugs that are like, getting back to our amazing keynote speaker, that are so targeted and used in certain types of diseases, they cure cancer 90% of the time. There's a drug called Gleevec for a certain type of leukemia. Whatever. If you give it to those patients, they cure cancer 90% of the time. There are some drugs that are used off-label in the 11th round of chemotherapy in someone who anyone would know has no likelihood of survival. The cost share for those 2 drugs are exactly the same. And I said, the time is now to improve access and lower barriers for the high-value drugs in this class and make it more difficult for the people to not get the drugs that they never should have been getting, that are putting pressures on their family and their estates and other types of things. And they stopped and they stood up when I said that. And I think that the nuanced part of that was what they knew every day, right? If people have to take out a second mortgage or foreclose on a drug that's going to cure cancer 99% of the time, I would advise people to do that more often than to take these shots that are going on in Portland and in Lewiston and Bangor and everywhere else in the country, because the communication about the relative value of these interventions are not being discussed.
Yeah, Mark, these are, great ideas.
I'm trying to provoke you. Thought-provoking.
You
Are you
are.
provoked?
You are. So cancer drugs or other things like that. I'm an employer, I'm a layperson, obviously. I mean, who's determining this? How do we get access to this?
And really good question. So we're stopping at noon, right?
Yes.
Yeah, 'cause I'm capitated. If I were fee for service, I'd go on past 12, but I'm capitated, so you want to put a fee for service clause in this? Okay. So this is the question. Your colleague to your left, who decides? This is really hard, and I don't expect any of you to decide. So, and if you Google me far enough, or Firefox me or whatever, you will find that I'm a death panelist. right? I'm somewhere in that discussion. And the beauty of this is that I ration dangerous care. So when I get these town hall meetings, and amazing when these people have these talking points and I say, I ration dangerous care, they're like, I want that care. I want you to give me stuff that harms me, right? So this is a very important point about this. Point number 2 in closing. VBID is not about coverage or not, right? That is up to the carriers. I'm saying once it's covered, something should be a little bit easier to get, and something should be a little harder to get, and something should be more easy to get. And this is the conversation that we're trying to build among stakeholders moving forward. How do we pick, right? So Andy knew in 2005, when he first heard about this, in 2004, that there are organizations like where he used to work at the NCQA, and at the American Diabetes Association, and the National Quality Forum, and the American Heart Association, who have been talking about high-value, evidence-based services for decades. They are the metrics on which we measure high-performing health plans, doctors, and health systems. We start at the very, very, very far edge to not get controversial. Right? Do you think immunization should be subsidized? Is what I told Speaker Newt Gingrich when I was talking about VBID. He said, yes. I said, now that you agree with that, we could have a conversation about what is good and what is bad. As long as you believe that any one thing is more valuable than another, you've fallen into the clinical nuance quagmire. And what has allowed us to move forward, Mr. CEO, is that as opposed to the Medicaid experiments in Oregon and the past, which are really stuck in the middle about the controversial areas, we have been over here with diabetic eye exams and immunizations and LDL checks, and under no circumstances will people say that is not codified by the evidence produced by the people who should know what's good and bad. Andy challenged me in 2005 to do the same on the stick side, and I responded then, December 2005, people don't want a general internist from Ann Arbor to basically say you should not be buying MRIs for back pain. It's the same answer I give 8 years later. The fact that the American Academy of Radiology and American Academy of Orthopedics is saying you should think twice about MRIs for back pain, this is why your timing is so perfect that I would argue incredibly strongly that you find some things that in the context of your organization that are underutilized for price and other matters, that you step forward and say, we are going to add clinical nuance and not make you spend a lot of money if you need a branded drug for diabetes or epilepsy or schizophrenia or whatever, that you're going to have this differential between $4 and 50% coinsurance. People like that. The carrots are what are popular. We've seen this in lots of companies. The PR is good. And I can guarantee you, in 4 or 5 diseases, it's not going to cost you any more money. It's not going to save you money, but you'll be neutral, not in a quarter, but in 2 or 3 years in diabetes and heart disease. You need to be like companies in Michigan who said, I need to lower my trend now. I couldn't do that in 2005. I wouldn't do it in 2012. I will do it moving forward with choosing wisely. And that's why I think, Nancy, you set up this meeting in a perfect way. Visit VBID, come call me, email me, tweet me, whatever. I'm happy to carry on a conversation with the group. I appreciate you inviting me. But I think that this is just the cornerstone, or no, it's more of a kind of a kernel of the larger issues that are going on. So clinical nuance matters in benefit design. I think relative to the other discussions in the meeting, hospital readmissions, I'm not so sure what an employer could do about that, right? ACOs, I'm not so sure what an employer could do about that. Changing your benefit design is something you could all get actively involved in. And the last point I'm going to make, and I don't want to be overly flippant about this peanut butter and jelly thing, is that if you, the employer community or broader community, start asking, how is this, what you're doing, aligned with what you're doing on the payment side or the supply side, is the question I implore you to ask. Because when those questions are asked by the business leaders, we have seen almost immediate change toward alignment. And it gets away from these, which I find very irrational situations where a key stakeholder group is encouraged to do something, and at the same time, the patients aren't. So I will end my capitated session on time. I am around for another hour and a half or so. Visit us, please follow us, and I hope you will evaluate us favorably. Thank you.
Thank you very much.